Good morning, good afternoon, good evening from wherever you're joining us from. Welcome to the Africa Health Business webinar themed Revolutionize, Boosting Africa's Infectious Disease Surveillance and Response Capabilities. My name is Valentine Kamau from Africa Health Business. At this time, allow me to highlight some guidelines for the session. Attendees will be on mute during the session, and we request all to observe allocated time during the session. The session will be in English and will last for 90 minutes. Please feel free to post your question in the Q&A section at any time during the session, and they'll be responded to as much as possible. There will be pop-up polls during the webinar as it progresses. Participants are encouraged to tweet during the session using the hashtag AHB2022. To highlight the session agenda, we will have 4 panelists. We will have a moderator from Africa Health Business, experts from Uganda Public Health Emergency Operations Center, the University of Nigeria, and the End Fund. Thereafter, we will have a Q&A session, parting shots, and panelists will finally conclude the webinar. And now, I'd like to invite the moderator of the session, Dr. Daniela Munene, Head of Consulting at Africa Health Business. Welcome, Daniela.
Thank you, Valentine, and a very warm welcome to the webinar participants who are still streaming in, and also a very warm welcome to our speaker who is present and the others are joining. So just a quick note on the program, we shall start with Prof. Becky Tagbo, and then thereafter we shall move on to the other speakers. But we're really glad that you could join this webinar. This webinar is the fourth in a series of webinars that Africa Health Business has been carrying out this year that is targeted towards strengthening Africa's health systems post-pandemic. And so this final one for 2022 is aptly placed as the last one because it's on infectious disease surveillance, which is still the biggest threat to health systems in Africa. The systematic collection, analysis, and interpretation of health data and the timely dissemination of the resulting information for appropriate action is essential for planning, implementation, and evaluation of public health practice. The World Health Organization proposes an integrated approach that coordinates surveillance of and response to disease to prevent unnecessary illness, death, and disability. Africa's capacity for early detection, confirmation, and response to public health threats has been tested time and again over the years, from Ebola outbreaks to the COVID-19 pandemic. Weak health systems, when strained and stretched by emerging threats, often backslide from routine surveillance, as was the case when COVID-19 caused programmatic disruptions of, for example, active case finding of tuberculosis, and neglected tropical diseases and others. As we recover from the pandemic, we must recover lost ground and further strengthen our surveillance and response systems that will remain responsive in the face of future public health threats. So it is my distinct pleasure to welcome you all to this webinar on how we can boost Africa's infectious disease surveillance and response capabilities. We shall hear from distinguished experts who shall give their experiences and the gaps and opportunities that they have identified, that if we collectively act on these gaps and opportunities, will lead to Africa building back better. So it is my distinct pleasure now to welcome Professor Becky Tagbo to take the stage and make her presentation. Dr. Tagbo is a pediatrician. She pioneered the WHO Afro-FED government rotavirus surveillance research for the first time in Nigeria in 2010, and thus headed the team that placed Nigeria on the WHO's global map of rotavirus reporting countries of the world to WHO global headquarters in Geneva in 2010. She is the site coordinator for WHO Afro-Rotavirus Interception and Pediatric Bacterial Meningitis Sentinel Surveillance in Nigeria. She's also a member of Africa CDC Expert Committee for the development of the Pan-African Antimicrobial Standard Treatment Guidelines for common infections and syndromes in pediatric patients. She is currently the director at the Institute of Molecular Medicine and Infectious Disease, College of Medicine, University of Nigeria. Welcome, Dr. Tagbo. We're really glad to have you here. Over to you.
Thank you very much, and hello, everyone.
Hello, and let me just remind the participants that there is a poll on their screen. Please answer the poll. It will just take a few seconds. Back to you, Professor Tagbo.
Yeah, so can I have my slides? Hello, everyone. You're all welcome. Thank you for joining. I'm going to be switching off my video for a better reception. Okay, so I'm going to be speaking on the theme of the meeting, which is revolutionize, boosting Africa's infectious disease surveillance capabilities. So can we go to the next slide, please? So this is going to be the outline of my presentation. Just a minute, I think I have an issue here. Just a minute, something on my laptop is blocking me. Okay, so this is the outline of my presentation. Next slide, please. Next slide. Yeah, thank you. So basically, my description of disease surveillance in simple terms is how do I pick up disease occurrences and do that as earliest as possible? How do I report or document as early as possible? How do I make meaning out of my data and respond earliest? How do I monitor to see that whatever I have raised, the issue, the outbreak, or whatever has been addressed? And how can I maintain vigilance thereafter so I can pick up subsequent occurrences, bearing in mind that this could be a completely new disease like the COVID that we're witnessing. And then how do I carry out all these in a coordinated manner on a large scale? It could be at countrywide scale or regional scale. Next slide, please. Next slide, thank you. So we all know that when diseases want to arrive, they do not announce themselves. In fact, if they had any choice, they would like to hide. So the way to pick it up is to put in place continuous, constant, sensitive, and untiring mechanisms and strategies. That is the only way we'll be able to pick them up when they come in. Next slide, please. The key words really in surveillance is sensitivity and responsiveness. But we can also include inclusiveness and comprehensiveness. If we put it in form of a question, how do we make surveillance more sensitive to pick up the disease at the earliest time possible? And how do we make it more responsive to the needs of the public? How do we then build capacity to do these two things? It has to involve the entire surveillance system, the processes, the human resources, the material resources, as well as infrastructure, and then the governance or leadership. Next slide. And so we all know that disease surveillance in Africa is relatively young when we compare to some other continents with many high income countries. Disease surveillance in Africa is still evolving or developing, and it has suboptimal coverages in terms of number of diseases and geographical area of coverage. And so the true burden of diseases are not really fully known. Next slide. So, as a result of it, some outbreaks are missed or are detected much later. Responses are not prompt or not well coordinated, and resource allocation, we all know, is also low, and the political and public perception of the need for surveillance is still growing. Next slide. So what are the strategies that we could use to boost surveillance? Leadership and stewardship challenge faces every government of all the countries in the African region. And this should be targeted at customized advocacy with which we can get the government to take up the leadership challenge and the stewardship challenge. There could be regional treaties or frameworks, for member states of the African region. Then boosting health system quality and infrastructure, as well as the health workforce. We need to raise the quality and the capacity of the health workforce, as well as the health system itself, and systematization of surveillance. This should be built into the fabrics of health and social activities of the society. In many places, surveillance still seems to stand alone, or at best, a little bit connected to the rest of the health system. We need to build it right inside the health services that we offer. Next slide. Other measures include weaving surveillance orientation and importance into the fabrics of the society's existence. That is, not just the health worker, but the entire society becomes so well-oriented in terms of surveillance, even at pre- and post-service trainings, like undergraduate students. We get surveillance built into the curriculum so that everybody just wakes up growing into the orientation of surveillance. Then the inclusiveness and comprehensiveness of surveillance. This refers to the number of diseases covered. We know that many diseases are still out of the surveillance picture. And then also, sometimes we just concentrate on lab-based surveillance without including the epidemiological and clinical components. We need to expand to ensure that we have a wholesome picture in terms of data. We also need to, in terms of inclusiveness, include both facility as well as population-based surveillance. We have to include private and public health sector. Of course, the public has to be on the driver's seat. The surveillance, we have to build it so that it will be response friendly. Build surveillance system with response in mind. From the beginning, what we aim is to pick up the issue and then respond to the needs, the outbreaks. And that means top-notch earlier signals and complete the loop. At the end of the response, we go back and continue our surveillance and don't end the surveillance. Next slide. Then we should also include resource mobilization. This is a fundamental issue. And we could consider a percentage of some form of tax, at the national level for surveillance, especially for the private sector. They need financial support, but even the public sector too. We can also have a modest percentage of the regional health spending. We could get the member states to, to sign to this, so that they can allocate a percentage, no matter how minute. I'm sure it will go a long way to dedicate it to disease surveillance. And then we cannot do without digitization of surveillance, electronic reporting and database responses. Paper databases cannot take us far. Next slide. So this is just showing the Nigerian model during the Nigerian Center for Disease Control, that is NCDC in Nigeria, had a wonderful Ebola response and actually received international commendations on the surveillance and the response system put in place. This was improved upon in this current COVID-19 response in Nigeria, and risk perception seems to be a key. Because of the high risk perception, everybody rose up to the challenge. And there was a partnership with the private sector. It was said to be good. And you can see on the right side of this screen, you see some of the documents that was published and had to do with the involvement of the private sector. Then down there, you can see the wheel and spoke model, where you have a hub, and then you have other facilities that are attached to that hub. And most of these facilities in the past have always been the public health facilities. Can you click again, please? And then, but you can now see that the private facility is involved in this. Next, please. So they are roped into that hub and spoke. So they are connected. So I will just do a few case studies for us to see what has been happening in some parts of the world regarding the private sector. In this case, we can see this was in India, just to show us that on the table, you notice malaria reporting. The official data was only showing about 1,000 deaths for malaria, while a study data showed us over 46,000. And when it came to dengue, we had 12,000 cases as official data, when you have 32,000 cases by research. That shows you that underreporting is heavy. And these authors proposed incremental steps in engagement of private sector, by the government through evidence-based strategies. We need to look for strategies that have evidence that they will work, so that when we employ them, we will have answers. And we need to include the public health sector. Next slide, please. Because of time, I'm not going to dwell too much on these other case studies. I will just mention the highlights. This one was in Iran, and they had to do a qualitative study involving focus group discussion as well as in-depth semi-structured interviews. And they had to analyze it using a thematic approach. And majority of the reasons for underreporting included complex reporting process. This made the private sector, to shy back from reporting, inadequate attention by the public health sector, inadequate physicians' knowledge, defective reporting system, and especially legal and ethical issues. They cited an example in a particular province where they were expecting report and they had zero reporting. But when they told them to remove the names, the identifiers of the patients, the reporting rose to 13,000 cases. So that is where ethical issue also comes in. Some of them do not also perceive surveillance as a priority. That is why we advocate for weaving this into the orientation of the public. Next slide, please. These are still some of their findings: lack of motivation, perception of individual clinicians feeling that all their job is to concentrate on the patient and the surveillance belongs to some other people, not realizing that public health impacts the individual patient's health. Lack of feedback. When we get these surveillance outcomes, we don't send it back to them. And so they concluded that independent or unilateral intervention is likely to have little chance of success and sustainability. In other words, we have to involve the private sector from scratch. Next one, please.
Professor, you have 5 minutes.
Thank you very much for that reminder. I think I will just talk about this number 3, and then we can move. So this is actually a case study from Anambra State. It is a state in Nigeria in the southeast. And it was a case of engaging the private sector, and they came out with results. And in this particular state or province, you have about 60% of health services being provided by the private sector, with a very weak collaboration between the public and the private. And what they did was, it was a sponsored, move to enhance the surveillance system and strengthen the health system. And so they had to start involving the private health sector, in a more active way in the stakeholders meeting, as well as providing them the surveillance data tools. And they did a training of about 862 healthcare workers on IDSR, with 30% of them coming from the private sector. Next slide, please. okay? And they were involved in data validation meetings, which they usually have involving all the districts. But this is usually just public sector, but they now involve the private sector in these meetings, procure documentation tools and give them. And then they had an orientation with the Association of General and Private Medical Practitioners. This was a very big boost. And what did they get? A lot of leap and improvement in terms of capacity. This project was actually sponsored by the European Union through the WHO. Next slide, please. And these are the amazing results. The response rate in implementation of policies increased, their knowledge on disease notification and response, as well as data management increased. The number of private facilities that were generating surveillance data rose from 48 to 165 within just about 6 months. And they had a significant coverage in TB services from 180 facilities in 2017 to 323 facilities, about 45% rise. And overall, they had a 23% increase in TB case detection, like 2,300 compared to 1,800 in the previous year. This achievement was actually an all-time high for that province. Next slide, please. So I will not spend time here. This is another case study. This was a systematic review, reviewing 40 studies. And they had a number of reasons or barriers for underreporting. And they made their conclusions, one of which is that government needs to take up the leadership and coordination challenge. Next slide, please. Also, I will not spend time here. This is another one done in the southwestern part of the country. And this was a cross-sectional study. And they had to interview 60 private healthcare practitioners. The summary is that 15% only regularly shared their data, but 90% were willing, but only 15 did that. And so they concluded that high awareness and knowledge was present, but poor practice. Next slide. And then this was now involved the entire southwestern region. And this was 507 private facilities involved in this study, looking at reasons for underreporting. In the end, they found that 34% had data collection tools. Next slide, please. Only 40% of them ever reported. Only 7% of clinicians could properly identify the data tools. Next slide. So, starting steps. We could start by first doing a mapping of the countries in the African region in terms of the proportions of public and private participation in surveillance through evidence generation. It could be previous studies, maybe a systematic review, and then current studies or some surveys administered to countries, so we can do a mapping and then develop a transition roadmap, a kind of pipeline with differing proportions, incremental proportions of public, private participation in surveillance. And then we can start with a hybrid model that is electronic paper, and then we decide and put some milestones of how we can increase the electronic and reduce the paper. And then private sector involvement needs to be wholesome. They have to be involved right from the planning stage. Next slide, please. Okay, so I summarize that disease surveillance and reporting is developing in Africa, is evolving relatively compared to other regions. There is gross underreporting, especially from the private sector. Government stewardship and leadership is required. There is need for sensitive and responsive, quality, inclusive and comprehensive disease surveillance system in the continent. We need to apply the boosting strategies outlined above. We need a sustainable funding strategies. We need to generate evidence as the basis for our strategies, and then do a mapping of the continent and so that we can then develop a roadmap on how we can achieve what we are looking for. Next slide. And next slide, please. Thank you very much for your attention. Over to you.
Thank you so much, Prof. I mean, those are some startling improvements in reporting with just a little bit of intervention. And, you know, certainly different countries can learn from those case studies, because if 60% of services are being provided by private sector and they are not reporting, in Kenya, it's just over 50% of services, then how are we making decisions nationally? So it's encouraging to hear just that very small interventions of training, giving the facilities feedback, making the reporting tools easy can dramatically increase the data that we're seeing and helping us to make decisions. On your screen, participants, you'll see a poll question. We want to have your opinion on which of these options would have the largest impact on improving Africa's infectious disease surveillance and response. Where does the weight lie? So please answer that poll question. As we move on to our next distinguished speaker, our next speaker will be Dr. Issa Makumbi, I believe. Yes. And Dr. Issa Makumbi is the Deputy Director, Uganda National Institute of Public Health, and the Director of Public Health Emergency Operations Center. He has contributed to the development of the WHO PHEOC framework. His role extends to mentorship of public health students and fellows, both nationally and internationally. He has been working in the health sector in various positions as a physician and a public health officer with over 35 years in the districts and national level. His experience has been in clinical and public health service delivery and management. He has overseen detection and response to over 30 outbreaks in Uganda since 2010 and has emerged as a leading subject matter expert on the global stage. We're really pleased to have you, Dr. Makumbi, and we are looking forward to hearing firsthand your experience over the years in effectively carrying out surveillance and response. Welcome, Dr. Makumbi.
Thank you very much. I have some slides with you. I hope you'll, I thank you for this opportunity. I am going to talk about the current landscape about and framework about surveillance and response capability, and also look at the stewardship of government to promote surveillance, and a little just briefly on the role of private and the opportunities which are there, and then I'll conclude. Actually, I'm very grateful. I agree with all what the professor has said, and also I agree with the strategies the professor has proposed. But for me, my presentation will be on a different angle, not on field studies, but let's see what I have on my slides. Next slide, please. As I said, I would also look at the landscape of capacities for surveillance and response in the world and also in Africa. In Africa or in the world, we have what we call IHR, that is International Health Regulations 2005, which really give us a guidance on how we can develop and carry out surveillance and response. We have IDSR, is an approach for African region, WHO African region, integrated disease surveillance and response. We also have another framework which also encourages us to know where we are on surveillance and response, joint external evaluation, JEE. We also have other measures like Global Health Security Index, that is the GHSI, And also we have One Health. And then the latest we have, which is not on my slide, we have 717 approach on how we can improve on surveillance and response. And I said before in the beginning on forward that the private has a role to play in many of these frameworks, which we have currently. And why I am saying that the private, depending on which country, it provides health services between 30 to 80. In my country, it's around 50, 49, 50 service provision is by the private. And these are not, you cannot ignore such a domain of private providers of health services. And as you asked, how do we make decisions leaving out all those? I want briefly to go in detail for those who are not very familiar with the integrated disease surveillance and response. Actually, Professor has mentioned about it. This is a strategy which we in Afro region are really implementing. It promotes improving public health surveillance, response for priority diseases, conditions, and events. And this strategy, for us who are low-resourced countries, it promotes rational and efficient use of resources by integrating and streamlining common surveillance activities and response together. It facilitates public managers and decision makers to improve detection and response and to make the evidence-based decisions. In a nutshell, really, the purpose of surveillance is to detect early a danger, for lack of another word, or a threat, and take appropriate action. Mark the word early detection and take appropriate action. And this you can do mainly through collecting data, or observing, doing data analysis, and get out information which is you can take appropriate action. So this is really, and the professor has already alluded to this already in her presentation on how we collect the data and analyze it and take robust and appropriate action. In fact, prompt action. Next slide, please. Next slide, please. I just again want, I'm still on this because this is the current and Africa-wide approach we are using for public health surveillance and response. It has some core functions of identify, report, analyze, investigate, prepare, respond, communicate, and evaluate. This can be applied at community level. It can be applied at facility level, district, regional, national level, including global level. Next slide, please. Next slide. I just wanted to again define what is public health surveillance. It's a continuous systematic different identification, collection and collation, analyzing and interpreting health data, including non-health data, to take timely and robust action so that you mitigate the impact, the negative impact of whatever threat you are detecting. It is essential for planning, implementing, and evaluating of public practice or interventions. And here in Africa, for us, we call IDSR is a vehicle for IHR. And I've already told you that IHR is at the global level. IHR is a driving force for IDSR. And I'll just tell you in a moment what is IHR. IHR is a legal, next slide. IHR is a legally binding agreement or instrument for the whole world to make sure that we don't allow diseases to spread across our borders. And this mainly, the purpose of this IHR is to prevent, protect, and control and provide response to public health emergencies or events which can harm our collective health, restricting ourselves to the risk which we are looking at, and to avoid unnecessary disturbance of trade and traffic. And this also obliges all countries, 196 countries, to build and sustain capacity to detect, assess, report, and respond. And that's why we in Africa, we implement this international obligation of IHR 2005 through IDSR, so that because we are able to meet all the requirements of the IHR. It's more efficient and integrates, as I said, all the functions of surveillance and response. The main source of data or information of IDSR is what we call indicator-based surveillance. This is a very systematic, well-structured system where we have regular reporting from known sources. And also we have event-based surveillance. This is ad hoc. Anybody can report unusual events in the community or in the environment so that the authorities can take appropriate action. Next slide, please. These are just of the core of IHR, where I think the private sector can really play a critical role in coordination, in preparedness and human resource and risk communication. I just to whet your appetite about the cores. Next slide. Next slide, please. And I said we implement IHR. This IHR is so critical. It is helping the world every day to protect the population of the world. That's why we are implementing IHR through IDSR. And as I have already told you, that the strategies are we detect, we confirm, notify, and take timely response, which caters for both IDSR and also IHR. Next, please. They synergize each other and cross-fertilize each other. The application of IDSR in our current Ebola response, as you know, I think I wanted to bring this to home or today, that IDSR has helped for us in Uganda to carry on preparedness and response. Preparedness in that so that we can prevent, detect, and respond to these public health emergencies. We have been able to build capacity at national, sub-national level, and at local levels, including the community. And we have also been able to develop and establish a network of laboratory so that we can confirm the pathogens we are dealing with, and of course train human resource to be able to do the surveillance and also to respond. We have also been able to train people to do risk communication and also a coordinating center, EOC, where I work, so that the public is protected and they know what the do's and don'ts. And of course, community engagement, where we have village health teams or village health workers who do voluntary work to report unusual incidents in there. And also we have logistics for countermeasures we've been using, and case management to treat those who have affected by the Ebola. So these are applications in IDSR, and that's exactly what we are using them to control our current Ebola. Next, please. Of course, for preparedness, it has helped us to establish the response structures, like established a emergency management committee, which we call it National Task Force. This is the body of government officials. It is multidisciplinary, multi-sectoral, including our partners. We have also established a well-trained response, emergency response team, which we call rapid response team. We have established the emergency operations center and a response plan in place so that if there is a problem, we just adapt that plan or amend it according to the incidents we have. And we have protocols in place, standard operating procedures, and we have a standing scientific committee so that we respond in a scientific manner or respond based on the evidence from either surveillance or other studies. Next, please. Next slide, please. The current challenges are that Africa today is ill-equipped to address emerging biological threats or infectious diseases. Because of the weak system, which are in terms of infrastructure, limited preparedness, lack of trained health workers, inconsistent supplies of diagnostic treatment and preventive commodities. The diseases are more epidemics are really in Africa, and as you know, the speed of the way these epidemics spread, they spread at the speed of a jetliner, because a jetliner, if it goes to America in 1 or 2 hours or 3 hours, you'll find the disease there. So the speed, that's why we need to be very, very strategic in our surveillance in detecting these, so that we comply with the IHR to control these epidemics at source, so that they don't cross our borders, to protect the other countries from getting the same calamity. We have, of course, limited funding, and the professor has mentioned it, especially sustainable domestic funding. And this way, really, the private can play a critical role in some of those aspects. And we are in this era.
You have 3 minutes. You have
okay,
3 minutes.
We are in this era of technology advancement, international travel and urbanization. Really, this is on the other side of the coin. It may be good, but also it has risks. And of course, we have sometimes unstable communities or timers. Next slide. Can you go to the slide? What needs to be done, or what needs to be done? Of course, the professor has talked about digitalization for real-time and early warning system, so that we can really take nip the bud when it's still early enough. So far today, the way we detect diseases using our surveillance system is not acceptable, because it can take from 8 to even 45 days. This is not acceptable. By the time you detect it, the calamity the magnitude of the problem is so high. So we need to work together so that we can work in solidarity, share information, so that we can all together, we can really control these epidemics. Next, please. This is what I wanted really to focus on. Stewardship of government to promote infectious diseases, infectious disease surveillance and response. We really need the government needs to promote the whole of society approach. This includes private. And I like the word the professor used, weave surveillance in the whole population. You weave it as if you are weaving a sweater, so that, you know, this is everybody's responsibility. It must be inclusive, so that we learn from each other. The government should have a public-private policy, which creates an enabling environment to work together with the private, so that we can put a dent on this risk. Collaborate with the private to remove barriers. Sometimes there are barriers between private and public, e.g. mistrust, but I think we can break the ice. We can invite the private. We can put incentives so that the private can work with us. We can also, the government also can establish National Institute of Public Health, where it can churn out disease detectors, disease people can really do surveillance, so that we can detect the disease. Legislation, government should put legislation so that we have a conducive environment today to work together and to make sure that this is everybody's responsibility to be part in the loop of surveillance. And of course, we need to empower communities so that they can report any unusual incidents. Next, I'm sorry, I have to finish. I'm going to finish. This could be one of my last slides. Okay, just let me just talk about the role of privacy, private sector. We need to work together to what I called epidemic intelligence, to develop the infrastructure for surveillance, systems for surveillance, so that we can create an early warning system which here is participatory, and we can report to each other. The RS system can help us to predict potential risks, and the private sector can help us in modeling using surveillance data. The private sector can help us to develop diagnostic tests or develop countermeasures like medicines or vaccine. Companies are there, you can develop these. Creating awareness and giving affordable care. Cooperative responsible resources could also go to surveillance. I know that private has what they call corporate responsibility resources, which we can put in surveillance. They can help us monitor dual use of research of life science. And of course, the private sector innovation can be very helpful in boosting the surveillance on the African region. The opportunities which are there is that the importance of sustained engagement by African countries with these other global domains like biological weapon, the global security, global dialogue. There is also United Nations Resolution Council 1540. The Africans can take advantage of this collaboration. And of course, the epidemiological levels from this private can help us to predict. So the private sector should collaborate with infectious disease prevention and control, so that we can underpin the values of efficiency, sharing responsibility, so that all of us are protected. Because when the calamity comes, it doesn't spare the private. Thank you very much, Chair.
Thank you, Dr. Issa. And we have all been following closely the Ebola outbreak in Uganda. And I must say, countries have learned from the prompt response of the Public Health Emergency Operations Center and the Uganda National Institute of Public Health. But the important thing is the cross-learning, that should such an outbreak happen in another country that maybe has never experienced Ebola, we can learn from each other. And you also really aptly bring out the role of partnerships between private and public. So thank you very much. In fact, it sets the ground for our next speaker. On your screen, participants, you'll see a poll question on the role of partnerships in infectious disease surveillance and response. Please type in your answer. We will sample some of your answers at the end of this webinar. And that brings me to our next speaker, Dr. Carol Karutu, who is a Vice President of Programs at the END Fund. Dr. Karutu has senior level experience working on HIV and AIDS, health system strengthening, maternal child health programs, including the provision of strategic, technical, and management leadership with international and local non-governmental organizations in Kenya, Ghana, Malawi, Mozambique, Uganda, and South Sudan. Leading USAID, CDC, and non-USG funded projects as a chief of party and project director is part of her experience. She has also been involved in using evidence to advocate government structures to allocation of resources, and raising resources from partnerships from all of society is her day-to-day work. Dr. Karutu, you'll correct me if I'm wrong, as you raise support to end neglected tropical diseases. Welcome, please make your remarks and your presentation.
Thank you. Good afternoon, everyone. It's my pleasure to be here today. And I don't have slides, but I'll speak from my notes. So I will start by telling you about the END Fund, because not many people know what the END Fund is, and by having this introduction, then you will get to understand how partnerships come in. So the END Fund is a collaborative philanthropic fund that's dedicated to controlling and eliminating 6 neglected tropical diseases. These diseases, the neglected tropical diseases, affect usually 1 in 5 people globally, and they include many that you know, the intestinal worms, river blindness, blinding trachoma, schistosomiasis, lymphatic filariasis, also known as elephantiasis, and visual leishmaniasis, also known as Kala-Azar. The health and economic and development impacts of neglected tropical diseases are severe. As I mentioned, they include blindness, disability, inability to work or attend school, stunted growth for children, and even early death. These diseases, as you know, many of them are treatable and also preventable, which is most important. The few that cause death, which is especially Kala-Azar, is one that's not as easily preventable right now. Our portfolio, we manage innovative and integrated and cost-effective disease elimination programmatic investments that aim at ensuring that those that are at risk of NTDs, which is about 1.7 billion people globally, have the opportunity to live healthy and prosperous lives. And we engage with community activists, the private sector, and take a systems approach. So we work with the private sector, governments and partners, and local implementing partners to collaboratively support and accelerate national disease elimination programs at scale. So our work in the past 10 years, we're just about 10 years old, has been mostly towards disease prevention, which we call preventive chemotherapy, management of those that have blinding trachoma, which we call morbidity management, or those that have hydrocele. However, in alignment with the WHO 2030 roadmap that seeks to eliminate NTDs, our role and our goals, as well as our strategic plan, has actually shifted to look at disease elimination and very much trying to see how many diseases within the 30 countries that we work, we have elimination. So with the WHO's 2030 roadmap for neglected tropical diseases, there is an emphasis on the importance of strengthened, institutionalized, and post-elimination surveillance. Because once a disease has gotten to a level, has been through preventive chemotherapy, been treated to a level where the prevalence or the intensity within the population is very low, we have to strengthen that disease post-surveillance so that these diseases do not, if they reoccur, then we are actually keeping an active watch. So to do so, the NTD sector, including my own organization, we are not only working to avail the improvement of diagnostics within the countries where we work, but also to improve a better understanding on spatial and temporal dynamics of transmission in low prevalence. Because like I said, 1.7 billion people are impacted by NTDs. That's a lot of people, especially intestinal worms. But what happens to a point where the prevalence gets to below 2%? That's what we call the low prevalence. So it's ensuring that we have in place a post-elimination surveillance that can keep us the fingers on that pulse for these in areas where we have these low surveillance. So to this end, the End Fund is right now, our programs, starting mostly last year, we're incorporating and integrating elimination surveys, disease mapping, in collaboration with national and subnational governments, so that we can we can optimize post-elimination surveillance platforms. This means working with already existing systems to strengthen those, to include, for example, in the case of Kenya, where we're looking to eliminate lymphatic filariasis in the next couple of years, or trachoma, is how do we ensure that we have that surveillance system to keep tab on lymphatic filariasis or trachoma in those areas that are being known to be endemic, but also with climate change in areas where we are seeing new foci of some of these diseases. Then in terms of when we think to do all this work, surveillance from where we sit is really a government job. It has to be stewarded by government. And for us, we come in to support. And as I mentioned earlier, our funding comes from philanthropists and the private sector. So we are a vehicle that mobilizes the money, and then we work very closely with the government and our local implementing partners to get us to the surveillance platforms and response that we need. So with the elimination of NTDs, the elimination of NTD, cannot be achieved without the stewardship of governments. The private sector and philanthropists can provide financial support, but without the government funding and leadership, elimination will not be sustainable. We can get to that low prevalence that I mentioned, but for that to be sustainable, then our governments, especially in the African continent, we have to be fully involved. Governments, again, must provide guidance to programs such as ours on how to really look at post-elimination surveillance. The guidance has to now begin to focus on post-elimination surveillance. How do we identify recrudescence in a timely manner so that we don't wait until an entire population is infected before we realize, oh my goodness, our lymphatic filariasis is back. And then what is the cost of recrudescence should it happen? Then we have to think about the sample. What samples do we look at on a monthly basis, on a weekly basis, at what frequency? And what are the sentinel sites and populations are we going to use to keep that pulse on the post-elimination surveillance? So those are some of the questions that we are hoping that the government can provide guidance and stewardship so that as we fundraise from the philanthropists and the private sector, then we're very clear as to what we're really fundraising for. As I conclude, the work that we've done at the End Fund is really through partnerships. We offer 4 sub-funds. So we call the End Fund a fund of funds. And these are investment opportunities for the private sector, for philanthropists, for foundations and corporations, so that you can choose and pick where you want to invest. So we don't give a one-size-fits-all. We have these 4 funds, which are very different from one another. So anyone in the private sector who is interested, if you're interested in supporting last mile elimination of, say, river blindness and lymphatic filariasis, we have a fund for that. If you're interested in seeing treatment just by itself, preventive chemotherapy, then we have a fund for that. If you're interested in deworming and the innovations that are there to break transmission of schistosomiasis and soil-transmitted helminths, then we have a fund for that. So our partnerships are really supported by offering products that the private sector, the foundations and corporations will be attracted to, but also meet their needs because everyone is interested in something different. So with this model, since our founding in 2012, as I indicated, we've been able to have up to 1 billion treatments, NTD treatments, in over 30 countries where we work, in Africa, in Middle East, in Asia, and also in Latin America. We usually will disperse about $30 million a year, and these go to governments, to NGO implementing partners, and we are looking to get to about $50 million a year as we work towards to achieve the goal of NTD elimination. Thank you for listening to me.
Thank you so much, Dr. Karutu, for sharing your insights with us and the lessons learned during your journey and your experiences during your journey. 1 billion treatments is no mean feat. So in terms of the open forum, which we're getting into now, I'll start with you, Dr. Karutu. Did NTD surveillance and response take a hit because of the COVID pandemic?
Yes, it did. So you just started with 1 billion treatment over 10 years. I can tell you very little. Usually between maybe 2015 and 2019, we were at 120 million treatments a year. But with COVID, we were not able to deliver as many treatments because a lot of the treatments, remember, occur through schools. So if the school, because it's children that are going to school are the ones that are most, when you deworm children, that's the cheapest platform, which costs about 50 cents a child. to deworm, because you already have the school platform itself. So yes, in terms of the NTD sector, delivery of preventive chemotherapy and medicines took a great hit. In terms of the surveillance, so for countries that were already, say, in post-surveillance state, or countries that were looking to do the transmission surveys that lead to preparation of dossiers towards elimination, all that work had to stall. So then in cases where, for example, you needed just one final round of treatment for you to go into your to your assessment survey, and you couldn't have that one round of treatment because you could not mobilize communities and bring them together to take, for you to be able to deliver the treatments. So just like with other health sectors and other sectors within our economies, yes, the NTD sector also suffered a lot with the COVID pandemic. And we're just, I would say we're still recovering. In 2021 and even in 2022, we haven't gotten to the level of treatments that we had in 2019. So we are still a little behind. It's taken us a while to recover.
That takes me to Dr. Makumbi, because right now it's a time of relative calm across the continent, with COVID having abated in our countries. I know in Uganda, there's still a lot of activity because of the Ebola outbreak. But Dr. Makumbi, how do you think we can prepare to continue routine surveillance, routine health services, even when we're really, really stretched by something like COVID-19 or any other threat that would come? How has Uganda managed to, even in the face of Ebola, continue with routine services? We don't want to be found in the same place when the next global threat comes along.
Yeah, again, thank you very much. But sharing experience and learning from past events, like we learned that in West Africa, the cases of malaria who died most were almost more, maybe more than that of the Ebola in that West African Ebola, and this was mainly because of the routine essential services maybe were missing, and we've learned that lesson. So for us, in all our planning, a plan for response must categorically put in the element of continuing essential services. And we have a separate committee or pillar to really make sure that the routine surveillance, routine health services, it continues, while the other teams take on the control of the outbreak or whatever risk they are trying to address. So for us, that's the way we handle to make sure that the essential health services continue running. Otherwise, we don't want to fall into that category where malaria killed more people than Ebola. So really, this is the lesson we learned, and that we make sure that in our response plan, this is really articulated very clearly that essential services have to continue. And we have a separate task force to do that. I submit, Chair.
Yes, that's an important point. And malaria deaths are even apparent in a short amount of time. The continent is still getting to terms with the long-term effect of disruption of immunization, childhood immunization. That one we don't see results immediately. We do know that it was interrupted by the pandemic. And so we may be facing a surge of infectious diseases in future because of such interruptions. And so, as you say, that underscores the need to really have surge capacity in our response. I don't know, Dr. Karutu, whether you feel, how do you feel the continent is doing in terms of building back better? If COVID-19 or a similar pandemic hits in 2023, do you think we've learned our lessons? Do you think we have strengthened parts of our health systems?
I think we haven't gotten where we need to be. I I'm a systems person, and I look around every single day and think about the systems that we have now. And I ask myself, our ER, and I'm not talking about NTDs now, our ERs better prepared, your emergency rooms better prepared than they were in 2019. And the answer to that, I wouldn't say it, but maybe you can respond to that. Are they? And that becomes the question. Regionally, how well are we actually working together to ensure that these pandemics, and in this case, we've talked a lot about Ebola, which is just in Uganda, our next door neighbor. How well are our governments and our cross-border surveillance really working to ensure that we can take care of, we can address an epidemic if it comes out in the next couple of months. And I'll talk specifically also to NTDs, which is not a pandemic, but we end up having, for example, outbreaks. So with visual leishmaniasis, the foci or the endemic areas will be northern Kenya, northern Uganda, the Karamoja area, areas in Ethiopia and in South Sudan. So if there is an outbreak of Kala-Azar or visual leishmaniasis in the Turkana area, that is likely to spill over in Karamoja and vice versa. However, there is very little that is on that border that helps the two governments like really think through that, yes, we have tribes that are moving back and forth these countries. One could be walking around transmitting to the other place. And I know for some of these diseases, we're now, like again, the visceral leishmaniasis, we're seeing cases in environments that we haven't before, in Tanzania, for example. And so the question is, how well are we looking at the cross-border? Because as much as we take care of our surveillance internally, as much as we have very strong public health institutes within Kenya, within Uganda, if there is really no collaboration that takes care of all these porous borders that we have, then the next COVID wave or the next epidemic, then we will see very much the same impact or even worse than we did in 2019, 2020.
Yes, we really must be more prepared. Professor Becky, your perspective on that same question. Have we recovered? Have we built back what we lost because of the pandemic? If another one were to hit, would we be more vulnerable or more prepared?
Thank you for the question. I hope you can hear me okay?
Yes, we can.
Yeah, it's a very important question. We've lost so much during this waves of Ebola and COVID. And the impact is on all aspects of human life, really. For instance, the WHO and the UNICEF is sounding alarm that immunization coverage has gone back 11 years. We are 11 years backwards since the pandemic. That is the highest in the last 3 decades. That is a very serious. So now, it is true that we're beginning to learn from the, from the pandemic. We need to strengthen our health system, our surveillance systems, cross-border, mechanisms and processes. But just like Dr. Caro said, we are not there. We are still far from there. If you just wake up and say, okay, we are back, COVID is less now, so let's just go on. You need to double to recover what you lost. If you continue the way you've been doing, you will be like 11 years behind, for instance. So there must be a catch-up planning. When a child recovers from malnutrition or from an illness, in fact, which has affected the nutritional status of that child, you need to plan a catch-up. The child does not need to feed normally, needs to feed extra to catch up for the lost weight. That is just the way it is. We need to plan how to double or even triple our efforts so that we can catch up from where we are before we even talk of progressing. So I think we really need to work harder at what we're doing, especially collaboration, and then applying the lessons that we have learned so far, and really come out with concrete steps. And this is not just at regional level, at country level too. People have to sit down and say, how do we catch up with this? This is where we were pre-pandemic, and now we've gone like 2 or 3 years backwards. How do we catch up and then progress? So it requires definite planning, not just business as usual. It wouldn't work that way.
Can I have also an input in that question?
Yes, Dr. Makumbi.
Can you kindly put my last slide? It has a lot to tell. Last slide. So really, my concluding remarks were that we can absorb shocks. We can absorb shocks, but we have not transformed. And that speaks exactly to the question you have talked about.
Yes.
And for us here in Uganda, we think that, as you said, build back better. We don't want the next pandemic to find us where it left us. And that's what you mean, build back better, or be prepared for the next pandemic. We have learned that when the pandemic came, COVID, we didn't have PPEs, and the people were supposed to go and rest and treat people, they were not protected. So that was really a very, very bad situation. So really, you can see that. So in that way, we think that the next pandemic, at least if it came, it will find us that at least we know. The last slide, please. We know how to make PPEs. We know. I was talking about the last slide, please. We know how. That one. So that we should build a resilient surveillance and response capacities, although we absorb the shocks, but we have not transformed for the next crisis. We can absorb, but we have not transformed. If transforming means like now we can manufacture our own PPEs, we have the materials here. That's transformation. You can see in South Africa, I think you are trying to make vaccines at other countries, even including us. So that next time we shall not be to this, vaccine is mine, not theirs, so that at least we can help ourselves. This is what I call transformation, so that we are prepared for the next crisis. So we can absorb, we can not transformed to make us resilient as an African continent. I submit here.
Very well said. We cannot just aim to be where we were before the pandemic. We have to become a lot more resilient. But one of the strategies I had Prof. Becky alluding to earlier is an all of society approach. And Prof. Becky, I was very fascinated by all the case studies you presented about involving private sector in reporting, because if we don't have data, then how are we making decisions? And I see a question from one of our participants, Ayodeji. He's asking, incentivizing the private sector, will incentives really help? Is it a short term? Will it only work in the short term? We need continuity for this data to be visible all the time. What is the best way to keep private sector engaged in terms of surveillance data?
Thank you for that question. Very important question. You know, people in the private sector, the private sector is such an opportunity for us. Like we have said, between 30 to 80, they contribute to the health sector. So they cannot be ignored. And we cannot be said to have a good surveillance system without them. So we can't even make our plans without them. They can't be ignored. Now, in bringing them in, some of the studies have shown that, for instance, you come to a private facility, some of them complained in some of the studies that they have to hire a staff just to take care of surveillance issues and fill in the forms. I mean, who pays for that? you know? So it's a kind of demotivating. And so one of the study was advocating that if we fashion this in such a way that they see it as a product that they produce, and then this can be purchased, that this can incentivize them to be able to do, give us good data, because they have the larger population. And that is why, like the person asking this question is very right. If you think of just handouts as incentives, you cannot sustain that. But there are other ways of incentivizing, for instance, infrastructure.
Yes.
You know, some of them complained of infrastructure, legal enablement, for instance. And then I did talk about if a percentage of of any tax or whatever it is allocated to surveillance. I know that in certain countries, for instance, they say education, 1% or 5% of value-added tax is allocated to building infrastructure in education. So when the government gets that percentage, what they do now is that all the registered private universities also benefit from infrastructure development, not just the public university. So that's already an incentive. You know, you build their labs, you help them build infrastructure and make it. So there are many ways to craft incentives in such a way that it will be sustainable. Thank you.
Yes, that's true. And I think also harnessing the sense of responsibility from private sector, because they are equally affected when there's
Sure. That's why the orientation is the basic thing, because some of them don't even have the perception. They feel this is actually a government business. How does that affect me? How does it even affect my patient sitting before me? But you notice in that success story, in one of those things, they had to have a meeting with the private practitioners and actually made them understand the importance of what we're doing. So it's all of that put together.
Shared ownership. Dr. Issa, you were saying something.
Yeah, I was saying that the incentives should be on the basis of mutual benefit. But however, their strategies like advanced marketing commitment, where the private can be really incentivized to really if you take tropical neglected diseases, why are they neglected? Nobody is doing very research and then giving products which maybe can help us to eliminate them, because the incentives are not there. Nobody is bothering. But if there were incentives, maybe you can see we didn't have incentives for Ebola vaccine, but now it's already on the market. And these are the kind of incentives I'm talking about. If there is some of these strategies can really incentivize the private, including technology transfer. That is also something which can benefit both the public and private, so that they can work together and really benefit both of them on both sides. So really, with this, the way we need to do to make sure that we really incentivize the private. Of course, we can use both the carrot and the stick, but it's better to use the carrot and work benefit together. Thank you.
Yeah, sometimes when you use a stick, people get even more innovative about hiding and cheating.
Yeah.
But that really brings me to Dr. Karutu, because, strategies that we can use to just increase our impact. There's a question from Eddie, and he's saying, what's the role of supporting innovations and young people in college who are doing research? And if they are supported, they might have innovations that can help in surveillance of NTDs, public education, name it. Is there room to support growing scientists and startups in terms of encouraging them to think out of the box and bring solutions that we have not tried before?
Yep, I think there definitely is room. So I took a minute to just think from our end. For example, right now we are supporting a startup that is testing a device that it's like a point of care. So it helps diagnose, it's a diagnostic POC that helps with the diagnosis of schistosomiasis in the field, so that you don't need lab equipment. So that helps with that quick diagnosis. So when opportunities like those arise, then we are able to actually think through it and see, is it within our mission, and is this something that that we can actually support? We don't do a lot of it, but it's something that we are thinking about. Then the other thing that we've also been considering alongside the surveillance is also like research and the local research institutions. And I'll give an example of actually most of the NTDs, and a good example is visual leishmaniasis, which doesn't affect that many people within East African region. It's about 15,000 people that are affected by this disease. No pharmaceutical company wants to make a drug for 15,000 people. No pharmaceutical wants to make a drug to a diagnostic for 100,000 people, because that doesn't bring a profit. So you find that many of the diagnostics and also the medicines, especially the medicines that we use for visual leishmaniasis and also cutaneous leishmaniasis, are way old type of medicines that are highly toxic to the body. So you are even more sicker from the medicine than you are from actually the disease, which again is fatal. So in this case, there's a lot of room for innovation. So if our research institutions begin thinking about this, because these are diseases that are affecting us within our continent, and then that's what then you are able to market to the private sector, but also within the continent, but also market to people like us whose job is really to fundraise from the private sector, from the philanthropists, and we can show why, for example, we need a POC or we need a diagnostic that will take care of people with 100,000 people that have VL within the East African region.
Exactly. Yes, thank you. So I'll just ask the speakers to just briefly in 1 or 2 minutes give your parting shots. And as they do that, there's a poll question for participants on your screen. So please fill in that survey. I'll start with you, Dr. Karutu, and in your parting shot, also address Isam's question about incorporation of NTD care or NTD prevention and promotion in primary health care.
Okay. So I'll start with NTD in primary health care. That is a major gap, actually, within NTD implementation, in that a lot of the NTDs there's been siloed implementation, which we are working really hard to change and see how do we have more integration within the health sector. So, for example, there's some NTDs that are case management. So, like there's the genital schistosomiasis, which a lot of medical doctors, a lot of our clinicians, actually, when they do the diagnosis, they actually think it's an STD, and it's not, because they haven't seen enough cases of genital schistosomiasis to actually even test or diagnose for it. So part of what you're doing this year is bringing together remotely doctors and clinicians within the African continent and begin working with them through training on how to diagnose genital schistosomiasis, and also how to then cascade that within the clinics where they work. So we are very much right now working to see that within the countries where we have influence, how do we get to that integration? Because again, with elimination, you cannot eliminate when you're in a silo, when no one knows that your disease exists and all that. So that's a big part of what we're trying to do now. And also in terms of financing for those that perhaps need surgery, for example, or those that are case management NTDs, ensuring those are included within the primary healthcare financing package where it actually exists. So those are some of the things that we're working on currently. So in terms of my parting shot is, as we Today was really about surveillance, about partnerships, about the private sector. And my experience in the past 2 years working very closely with private sector is we have to stay innovative. What was interesting to them last year is no longer interesting to them now. So how do you keep them interested? Because we know if you're implementing something, it will not take 12 months, but to them, their interest is very, very limited. So thinking through as we do our work in public health, how do we keep them interested? So whatever was there last year this year is not even anything. It's no longer innovative. So it's really keeping that going. Thinking, like keeping us on your toes as we try and think through new versions, new innovations that keep them interested. And then the other piece is the urgency. The private sector likes urgency because if you're not showing any urgency, they're like, why are you so slow? So how do we show some urgency in the work that we do? Yes, indeed, everything is backed by research. Research is important, but even as we think through research, how do we expedite some of what we already have or what we already know by using the current data that we have to inform and make changes to our current strategies. And with that is we have to show value for money. If you don't show value for money, like we talked about the treatments, or we talked about the surgeries, you have to show value for money or the systems that you've integrated. So showing value for money. And then finally, without the stewardship of government, anything we do is not going to be sustained. So bringing together, ensuring that the government is stewarding everything that we're thinking about and being at the lead and showing them why it's really important that they're there, then I think we will succeed if we do that. So thank you.
Thank you. Prof. Becky, your parting shots.
Thank you very much. I would like to remind us that mobility is very high, just like Dr. Issa reiterated, in this current global society. Mobility is very high, and that is how disease is going to be moving as well. And in the consciousness of that, knowing that in many of our countries, the private sector caters for the greater population, at least in my own country, that's about 60%, then we must bring in the private sector full speed, to join in surveillance. And this we have to do through all the measures that we have outlined, especially bringing them in every process, every step, every meeting, every planning, and then getting them to perceive surveillance as important as it is. And in doing this, the leadership has to come from the government. It is the public sector that will have to involve the private sector, just like in one of the case studies that I shared. And finally, there is need for sustainability. And this, we can see that, in fact, one of the case studies said that some of the private sector people said that government, some of their surveillance lines are usually very transitory, that when they come for data this year, by next year, when you give them the same data, they say they are no more collecting it. It is simply because donor funding has ended. And so it's not that disease has ended, but that surveillance has ended. So we need to, as a continent, look for indigenous sources of funding in a sustainable manner, not probability. We can structure it that it becomes sustainable, and we can, based on what we expect, we can then build on how to distribute that fund to fund surveillance in both private and public sector. Thank you, and over.
We need to be cured from the disease of programiosis, where health providers and as health professionals, we only identify with our program. And once we're out of the program or the donor funding goes, that's it. Dr. Makumbi, your final remarks.
My final remark is that surveillance capabilities are continuously needed. It's a continuous agenda which we need really to continue working on. Neglect, for lack of better word, the private, because the private has a very big role to play in the building the capabilities of surveillance and response, depending on where we are. But to me, the private really is very important because the private provide a lot of services to our audience or our population. So we don't need to really to leave them outside all decisions, and we should look at their cooperative advantages so that we can really benefit from them. I am coordinating here in Uganda what we call private round table, private sector round table. It's a global companies who are interested in making sure that the global security agenda is fulfilled. So I'm coordinating those, but I see them, they don't write a check for us, but we work together and we learn from each other and really we benefit together. So we should not really neglect the private sector. We should really invite it, and we should the government should be in the leadership seat, and then we benefit all of us together. I submit.
Thank you very much. Participants, there you have it. You've heard it from the experts on how we can boost Africa's systems to better deal with infectious disease surveillance and response. Now let's have a look at the results of the poll questions. 77% of respondents felt that Pan-African institutions and organizations, governments, global health institutions, and private sector collectively are best placed to boost the capacity of Africa's infectious disease surveillance and response. Indeed, an all of society approach. And in terms of the next question, we had asked you which of the following would have the largest impact on improving Africa's infectious disease surveillance and response. And the largest response was investing in digital health systems that integrate multiple surveillance systems. This is something for policymakers to take note of. I think digital health is an enabler. I'm not surprised by that result. And then finally, we had asked you to let us know the role of partnerships in infectious disease surveillance and response. And we have a number of responses here. I see financial support, policy formulation. Partnerships can also have a role in detecting possible outbreaks, ensuring intersectoral, multisectoral collaboration, enhancing collaborations in multifaceted approaches in dealing with a situation, dealing with capacity gaps, early identification and management of outbreaks. Thank you very much for your insights. And this brings us to the end of our webinar. Thank you very much for staying engaged, participants. And thank you very, very much to our speakers for your wonderful and thought-provoking insights. Africa Health Business will bring to you a conference, a symposium on the role of the private sector in advancing men's health in Africa in Nairobi on 24th November 2022. You can scan to register and attend that conference in Nairobi. If you're not able to come in person, it's a hybrid event. You can follow along online, and the registration details are also in the chat on your screen. We also are participating in the second international conference on public health in Africa, hosted by the Africa CDC in Kigali, Rwanda on 13th to 15th December 2022. Africa Health Business is hosting a track on whole of society approach in combating COVID-19 and emerging diseases. Please start making your arrangements to travel. Let's meet in Kigali in December for this very important Africa-wide conference on public health. Thank you very much. If you'd like to contact us, you'll see our contact details on the screen. We'll see you next time.
Thank you. Bye.
Thank you, moderator. Thank you, moderator. That was good.
Thank you. Asante sana.
Sana, sana.